everyone. On behalf of Adley Oncology, I would like to welcome guest speaker of today's webinar, Dr. Amir Zidan from USA. I would also like to welcome discussants of today's webinar, Dr. Roshni Pandey, Group Captain, Dr. Harshit Khurana, Dr. Shilpa Prabhu, Dr. Ayan Bhattacharya, Dr. Akshay Shah, Dr. Philip Chepsi, Dr. Giripunja M, and Dr. Kunal Goyal. Before we proceed further, I would like to take a couple of minutes to present you what exactly Adley is doing currently. So once again, greetings from Adley Oncology. You build hope, we accelerate it. Every moment of life is precious for cancer patients. Today, we are one of the fastest growing oncology company in India today. Why we are fastest growing? Because of our own manufacturing. So we do have our own state-of-art manufacturing facilities in India and Uzbekistan. In fact, we do have 4 cytotoxic plants, out of which 1 plant is of API. So we are truly a backward integrated oncology company. We do have presence in majority of the corporate as well as government hospitals across the country. Our major focus is on new product development. Last financial year, we have introduced 6 novel molecules. And in this financial year, once again, we'll be introducing around 8 new molecules. 3 we have already introduced, and 5 more molecules will be launching in next couple of months. To start with, we'll be launching afatinib, pazopanib, rucaparib, azacitidine and carfilzomib. Then our major thrust is to bring cost-effective medicines, and last but not the least, our emphasis on patients first approach. Currently, we are available in more than 60 countries globally. We have already triggered audit for PICS and INVIMA, and once that is done in next 6 months' time, we expect that we'll be available in more than 50 countries globally by 2025. Patient first is our guiding principle. Our first priority is patient compliance. So Adley is the only company in India to having lot of NDS formulations. Like we do have NDS formulation for docetaxel, gemcitabine, paclitaxel, and very soon we'll be launching azacitidine oral. The second priority is the patient support program. So this is the best and the unique program from Adley, where the drug support reaches to the patient within 24 hours time once the consultant put the request to us. Third is the patient education to disseminate knowledge through awareness programs like Champions of Hope, Burst the Myth campaign, which we have just recently concluded. And last but not the least, the providing cost-effective medicines. As we have our own API, it enables us to maintain highest quality drug at cost-effective rates. Your wish can become a reality now. Long-term survival is possible in relapsed AML patients with azacitidine oral. So very soon we'll be coming out with azacitidine oral, and our brand name will be MDS-O. Without taking much of your time now, to commence the event, I would like to invite Dr. M.B. Agrawal sir, who is teacher of teachers. Thank you very much. Over to you, M.B. Agrawal sir, please.
Is my screen visible?
Yes, sir.
Thank you. Good evening, one and all. Thanks to Mr. Ashutosh Shukla. Our guest speaker this evening is Dr. Amir Zidan from Connecticut, US. He'll be speaking to us on novel therapies for MDS. This webinar is brought to you by Mumbai Hematology Group. It is supported by Adley, managed by Mice Ideas. I thank Mr. Ashutosh Shukla and the team from Adley, Mr. Rajesh Kalpesh and the team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Amir Zidan from Connecticut, US, all our discussants who are very eminent hematologists or medical oncologists from this country, and you participants for sparing your Saturday evening for academics. As was mentioned, it's my pleasure to introduce the discussants to you. We have discussants today from Jabalpur, Pune, Bangalore, Kuch Bihar, Mumbai, Kerala, Bangalore, and Kolkata. Dr. Roshni Pandey is consultant medical oncologist at Mahakoshal Hospital, Jabalpur. Group Captain Dr. Harshit Khurana is Senior Advisor Medicine, Clinical Hematologist and BMT Physician, Command Hospital, Southern Command, Pune. Dr. Shilpa Prabhu is consultant hemato-oncology in bone marrow transplant, Majumdar Shah Medical Center, Narayan Hridyalaya, NH Health City, Bangalore. Dr. Ann Bhattacharya is Director Clinical Oncologist at Regional Cancer Center, Kuch Bihar, West Bengal. Dr. Akshay Shah is Director, Conquer Cancer Daycare Center, Consultant Oncologist, Stem Cell Transplant Physician at Nanavati Hospital, Raheja Hospital, Global Hospital, Mumbai. Dr. Chepsy Philip is Senior Consultant Program Director of Regional Advanced Cancer Center for Transplantation, Hematolymphoid Oncology and Marrow Diseases, Believers Church Medical College Hospital, Tiruvalla, Kerala, Giri Punjab, Department of Hematology, Manipal Hospital, Bangalore, and lastly, Dr. Kunal Goyal from Institute of Hematology and Transfusion Medicine, Medical College and Hospital, Kolkata. Just to introduce you to what's there in the next 8 days. We have a very active program in the next 8 days. Tomorrow morning, Sunday, 14th November, 11:30. For the first time, we are covering the subject of LGL leukemia. And our guest speaker is Dr. Lemy from France. Midweek on Friday, we have a webinar on acute lymphoblastic leukemia with our colleagues from India as the speakers. On Saturday, we have got 2 of them. Early in the day at 4:30 p.m., we are going to have a discussion on oral azacitidine and its place in the treatment of AML and MDS from none other than Dr. Andrew Wee from Melbourne, Australia. In the later part of Saturday, 7 o'clock, we have polycythemia vera and essential thrombocythemia by Dr. Prithviraj Bose, who is from MD Anderson Cancer Center, Houston, Texas. And lastly, on Sunday, we got once again an unusual subject of hemophagocytic lymphohistiocytosis. Dr. Rafael Makovics from an unusual place, Poland, is our speaker. He has spent all his last decade working only on HLH. So these are the webinars lined up for you in the next 8 days. Now it's my pleasure to introduce our guest speaker for the day, Dr. Amir Jaden, Connecticut, US. He is not an unknown personality to you. He has been speaking to us in past. He has become our friend, colleague, and an expert in a number of diseases. He is an associate professor of medicine, hematology at Yale University, and the medical director of hematology early therapeutics research at Yale Cancer Center, New Haven, Connecticut, US. He completed a hematology oncology fellowship and a clinical research fellowship in MDS at Johns Hopkins University, where he also earned a Master's of Health Sciences degree in clinical investigation. He specializes in the management of acute myelodysplastic leukemia and myelodysplastic syndromes. The focus of his clinical and translational research is the development of novel therapeutics for myeloid malignancies with a focus on targeted therapies and use of immunotherapy-based approaches. He has and continues to serve as the principal investigator on many investigator-initiated cooperative group and industry-sponsored clinical trials for myeloid malignancies and chairs or serves on the steering or independent data review committees of several large clinical trials for myeloid malignancies. He has received several prestigious awards, including the Leukemia and Lymphoma Society's Scholar in Clinical Research Award, the NCI Cancer Clinical Investigator Team Leadership Award, the AAMD SIF Evans Foundation MDS Clinical Research Consortium Fellowship Award, the Tito Veciano Young Investigator Award, the ASCO Young Investigator Award, and multiple other achievement awards. He has presented his research in many important meetings and has been an invited speaker nationally and internationally. He was the lead presenter of MDS Review at the ASH 2018 Highlights meeting in US and Asia Pacific. He's authored over 180 peer-reviewed publications and book chapters. He serves on the editorial board and a reviewer of several important hematology and oncology journals. He is active in health outcomes and comparative effectiveness research for blood cancer diseases and their therapies. It's my pleasure to invite him to deliver his talk today on novel therapies in myelodysplastic syndrome. Thank you. And over to our guest speaker now.
Can you hear me, guys? Yeah, there's something wrong with the audio. So I have the phone on, but it's causing an echo. Is there a phone number I can call? Let me try this. Is this any better? Yeah, my audio is on. I think there is some issue with the feed, but if you can hear me okay now, can you please indicate?
Yes.
Okay, I can hear you through the phone now. So let me put the slides up. Sorry for all the confusion. Let me put here.
Hello, Dr. Amir.
Yep.
If you can share the slides, sir.
Yes, let me just get out of this quickly. Okay, I'm hoping now you can see my slides. It's always fun in this Zoom era to try to figure out all the technology stuff. So thank you very much for the kind introduction. I could not hear a lot of it because of the audio issues, but I'm happy to be here with
Hello,
you today.
Dr. Zadan.
Yes.
Sir, sorry to interrupt. It is in the presenter view we can see right now.
Okay, let me see.
Put it on a full screen, sir.
Is this better now? Was it still in the presenter view?
Yes, it is perfect, sir. Good to go.
Perfect. Okay. So again, sorry for all these technology issues. I'm happy to be here today to talk about novel treatments for MDS. So these are my disclosures. So today I'm going to overview MDS, and I'm going to give an overview of the current treatment landscape before we go into the novel drug treatment for MDS. And of course, MDS is a very dynamic field. It's following on all the developments that has been happening in acute myeloid leukemia. And I foresee that the landscape is going to change significantly over the next 5 to 10 years. So I think one of the points that I always like to make when I present about MDS is the importance of making the right diagnosis, because there are many challenging conditions that can present as MDS, and knowing the right diagnosis is very important. So here you can see one of the schema that I follow in my clinic, where we exclude nutritional deficiencies, we exclude other drug effects or other factors that could mimic MDS. And the second point I always like to make is that MDS is a cancer. We have many patients who come to us being told that they have anemia and they do not have basically a cancer, and they get surprised when they hear it. But as you can see in this real life data registry from the US, the median survival or the 5-year survival with MDS is 30%, slightly higher than AML, but still pretty bad, much worse than most other cancers, as you can see. So it's a pretty bad cancer when you take it all over the population. And the classification of MDS has evolved over time. You can see here the different classifications through the different iterations from the WHO. And that remains important because the management is still dependent on the prognostic picture of the patient. For example, patients who have refractory anemia with excess blast or MDS with excess blast, they have a median survival of 12 months, while those patients who have lower risk MDS, such as refractory anemia, have a median survival of more than 4 years. So it's very important to make a precise prognostic picture to counsel the patient and recommend the right treatment. But we know that the pathologic picture by itself is not enough to risk stratify. We know the importance also of the cytogenetics and the blood counts. And because of that, multiple scores have been developed to try to define the correct prognostic picture for each patient. Some of the most commonly used scores, you can see them in this slide, such as the IPSS, the revised IPSS, the WPSS, and the MD Anderson score. And all of these are in practice. For a long time, the most commonly used system was the IPSS. And you can see it's based on the blast percentage, the cytogenetics, and the number of the cytopenias. And then you add these numbers together and you come with a prognostic group that reflects the survival as well as the risk of progression to acute myeloid leukemia. However, the accuracy of this system was not ideal, and therefore the revised IPSS was introduced in 2012, in which instead of 3 groups or 4 groups, we have 5 groups. As you can see here, very good, intermediate, poor, and very poor. And you can see that there's a huge difference also in overall survival based on the group, all the way from 0.8 years to 8.5 or 8.8 years, as well as in the risk of progression to acute myeloid leukemia. And this has become the standard system that's used in most academic institutions as well as in clinical trials. Of course, it's a complex system, especially the cytogenetics. I do MDS day and night, and I still cannot remember all the details of it. So we often use, these online calculators or applications on the phone to determine the specific prognostic class of the patient. I like to highlight here that in patients with therapy-related MDS, for a long time, those patients were lumped together as one bad disease entity, and transplant was being recommended. However, we and others have shown that therapy-related MDS, while as a group, most of those patients do poorly because they have an increase in the bad cytogenetic and molecular markers such as complex chirotab and TP53. There are some patients who develop MDS basically that are lower risk really. So you can see here that among patients with therapy-related MDS, the IPSS and the revised IPSS still stratifies patients with very good accuracy. And you can see the very low-risk groups in IPSS and revised IPSS can have prolonged survival. So therefore, we still recommend treatment of those patients according to their risk group rather than just taking all of them to transplant. And the prognostication MDS is challenging because not only it depends on disease factors such as IPS, such as the genetics and the blast count, but also other factors from the patient themselves, such as their comorbidities, the echo performance status, the presence of other cancers. So you really have to think about the patient as a whole and not just about the risk tool that you are using when you making therapeutic decisions about the patient. So as I mentioned, the revised IPSS has become the most commonly used prognostic tool. The survival of patients within each tool is highly variable. And I'm showing you here some of the problems of the revised IPSS and why, again, it's important to think of it as a tool rather than just follow it blindly. We discussed that comorbidities are not accounted for in the revised IPSS and most other scores, but you have to account for it clearly when you make therapeutic decisions. Currently, we don't have molecular data incorporated in the revised IPSS, but actually several attempts have been at including molecular data in prognostic scores. And in this upcoming ASH 2021 meeting, there will be presentation about the molecular IPSS in which molecular alterations have been integrated in the system. So we'll see if that will replace the revised IPSS. Other issues that are important to remember is that the risk group for each classification can give you only the survival as a group, as a median for that group. However, there's a lot of variation, as you can see in this figure. So some patients within each group can do worse than others, and some patients can do better. So again, important to, when you tell a patient that this is your prognosis, to tell them that this is a group estimate, not an estimate for the particular patient. The other thing to remember is we talk about lower risk MDS all the time. However, the revised IPSS and the IPSS, there are some patients with a low risk disease who do very poorly. As you can see here, for example, in this data analysis for patients with lower risk MDS by the IPSS, you can see that around 1/4 of those patients died within 2 years. So not really every patient with lower risk MDS by the IPSS really have an indolent disease. And again, that was an important reason why other systems have been developed. Another challenge with the revised IPSS is the intermediate risk group, because we often don't know exactly where to put those patients. We have the high, very high, and then we have low and very low, but the intermediate risk sometimes can belong in the high risk and sometimes can belong in the lower risk. And that actually is the same in clinical trials. Several clinical trials include intermediate patients in both higher risk and lower risk treatment interventions. I'm showing you here some of the methods that I use in my clinic to decide whether I treat a patient as a lower or a higher risk. For example, if studies have shown that patients who have an intermediate risk group of 3.5 and basically would be lower risk, while if they have 4 and 4.5, they would be higher risk. Other studies have shown that from a transplant perspective, taking patients to intermediate risk group give them the best life gain. And there are other risk tools that have been specifically developed for patients with IPSS. So I think these are all important and useful ways to help you work with patients in the clinic. And we discussed that there is an increasing number of molecular alterations that also impact the prognosis, but also serve as therapeutic intervention points that you can use for your patients, such as the IDH mutations and the rarely FLT3 mutations. However, I think from a prognostic point of view, the more mutations you have, the worse the outcomes. And we will see how the revised IPSS will have the incorporation of the molecular data. Now, shifting gears to the treatment landscape of MDS. So in the next few slides, I will be talking about treatment for lower risk and high risk MDS as the current treatment strategies that are available. And then we'll talk about the drugs that are in development, especially in advanced development. So erythropoiesis stimulating agents have been among the drugs that have been used for the longest time for patients with lower risk MDS. They are, on average, around 40% of patients with lower risk MDS and anemia will respond to ESAs. However, the response varies based on the erythropoietin level and how much transfusions is the patient getting. With patients who are getting a lot of transfusions and have high EPO levels, as you can see in the Scandinavian risk tool, they have a very low predicted response to ESAs. And therefore, some patients will benefit from other drugs, such as lenalidomide. So lenalidomide is an agent that we are using in clinical practice all the time. The initial approval was for patients with deletion 5q, lower risk MDS, where the response rate with this oral drug have been around 67% in terms of transfusion independence. So it's very active, and many patients achieve cytogenetic responses. The duration of response is durable, around 2 years. However, patients who do not have del5q sometimes benefit from this therapy as well. We tend to use it in the context of following ESA failure, or in patients who have very high EPO level who are not likely to respond to ESAs. The response rate is not as great, as you can see to the left side of the figure. The chance of response is around 25%, and the duration of response, the median time, is only around 30 weeks. So again, not very durable response. And therefore, there has been an interest to look at other drugs. Luspatercept has been approved in the US in the year 2020. based on the medalist trial, which I'm showing you the top results here. So luspatercept is a ligand trap. It basically works on the transforming growth factor pathway by trapping ligands that are important for the effective erythropoiesis that happens in MDS. So this drug is given by subcutaneous injection. It's every 3 weeks. I'm not sure if it has been approved in India yet, but it's approved in the US and I think in other countries, and we are using it right now routinely in clinical practice. The transfusion independence among patients who have ring sideroblast. So initial data suggested that patients who have ring sideroblast tend to respond the best. So among those patients, the response rate is around 38%. The durability of the response is not the best as well. It's around 30 weeks, so around 8 to 9 months. And therefore, while it's a useful option, many of those patients will eventually worsen and need transfusions again. As I mentioned also, it's approved for patients with ring sideroblast, but there are ongoing trials we'll talk about later that are looking at other disease subsets that might benefit within the MDS spectrum. Shifting gears to higher risk MDS. So azacitidine is a hypomethylating agent that has been approved and is actually the main treatment for higher risk MDS. This was based on the AZA-001 trial, which is a landmark trial of azacitidine versus conventional care regimens, where you can see here that the survival has been improved to 24 months compared to 15 months, and with a hazard ratio of 0.58. And based on this data, azacitidine is very commonly used. Another hypomethylating agent that's used in the US and other countries is decitabine. So decitabine, in contrast to azacitidine in the randomized trials, has not improved overall survival. However, there has been improvement in transfusion independence, improvement in responses, objective responses, as well as improvement in quality of life. And I think a lot of the feeling right now is that some of the differences between the decitabine and azacitidine in clinical trials were related to the clinical trial design rather than necessarily differences in biologic activity. So one of the common questions I often get is, which hypomethylating agent do you use, since azacitidine has been the one that has been shown to prolong survival? This is a question that I evolved over time with, because we have conducted, and many others have conducted, multiple retrospective and data and registry type of analysis comparing azacitidine and decitabine. This is a large registry, the SEER Medicare in the US, for patients who have refractory anemia with excess blast, which we use as a proxy for high-risk MDS. And here we showed that the response rate was similar, or the survival was similar between the two drugs, between azacitidine and decitabine. And for that reason, I tend to use both drugs for patients. I don't have a preference for azacitidine over decitabine. Important to remember that hypomethylating agents are slow to work. They can take 4 to 6 months before a full response is observed. So it's important not to stop the treatment very early, which is one of the common, I would say, issues that we see in clinical practice. Also, some patients will have deepening responses with time. So initially they would have stable disease, but then that stable disease, if you continue therapy, as in this secondary analysis from the AZA-001 trial, showed that with continued treatment that the responses have deepened. So in general, I tend to keep the patient on treatment for 4 cycles and do a bone marrow biopsy. If the patient has reduced in his blast count or stable disease, I would continue, because some patients will have converted to full responses. Another common question I get about hypomethylating agents is, do I switch between the drug? Do I switch between azacitidine and decitabine? And we actually have data that switching doesn't work very well. If the switching is because of resistance, because there is significant overlap in resistance between decitabine and azacitidine. However, I do switch in situations where there is intolerance or some side effect, because sometimes those don't necessarily overlap completely. I think also also very important to remind the audience here is that we always talked about MDS as the only way to cure it is by bone marrow transplant. However, we did not have a lot of kind of high-level randomized data to support this. And in the last year, we have 2 papers published, one from the US and one from Germany, in which biologic assignment was used. So you cannot really do randomization, full randomization, because of the donor availability. So with biologic assignment, patients who have donors and went to transplant have done much better than patients who have received basically only hypomethylating agents without going to transplant. And you can see here that the overall survival at 3 years has been improved by 20%. So again, it's very important to counsel the patients about the importance of going to transplant if they are fit. And you can see this extends up to the age of 75. So it's not only for younger patients, it's up to the age of 75. If the patient is fit, we would recommend going for a lower intensity transplant. However, as expected, many patients are afraid of transplant, and they would come to us and say, well, I'm responding to hypomethylating agent. Can I just stay on azacitidine or decitabine? And what are my chances of having long-term survival? Because every one of us who treat these patients have few what I would call super responders. So you have patients who are on the HMA for 4 or 5 years. So we conducted this analysis also within SEER Medicare to try to understand what is the likelihood that the patient who is on HMA would still be alive at 5 years without going through a bone marrow transplant. And as you can see here on those figures, the likelihood is quite low. It's only 4% for patients at 5 years. So again, suggesting that the chance of survival without bone marrow transplant is very low. And therefore, we would recommend going to transplant for every patient who is fit and has a donor. Now, starting to talk about some of the new therapies that are in advanced development. And this one is actually already approved now in the US. It's an oral version of decitabine. It's called Aztec 727. The trade name or commercial name is Incovi. And it's a combination of cedazoridine and decitabine. So the reason why you cannot take decitabine by mouth is that decitabine is metabolized in the gut and the liver by this enzyme cytidine deaminase, and therefore very little will reach the systemic circulation. Here, in this drug, cedazoridine, which is an inhibitor of this cytidine deaminase, was combined with decitabine in a once daily pill, and that inhibits the enzyme, and therefore decitabine will arrive into the circulation. And based on this large phase 3 trial called the Ascertain trial, the drug was approved in the US. However, this trial compared the pharmacokinetics basically of the 2 formulations. The way the trial was designed is that patients were randomized to the IV or the oral versions in the first cycle. In the second cycle, they would switch to whatever they were not getting. So if they were on IV, they would go to oral. If they were on oral, they would go to IV. And starting the third cycle, everybody is getting the oral version. So therefore, you cannot compare long-term outcomes because everybody is getting the oral version starting the third cycle. But the primary endpoint, which was the pharmacokinetic equivalence, suggested that the 2 drugs were very similar at 99%. And based on this data, the drug was approved in the US. This trial has been presented more than once, and there's an update in this ASH 21 that will also have updated data. But what you can see here is that the complete response rate is around 20%, which is somewhat similar or slightly higher than what you see with injectable hypomethylating agents. And the median duration is 14 months. So I think of this drug as being very equivalent to IV decitabine and subcutaneous azacitidine. And I tend to use it based on the logistics. For example, patients who live far, who don't have someone to transfer them back and forth, they might benefit from this oral option. However, the fact that you're using an oral option should not make you forget that you are treating a patient with aggressive cancer, and therefore those patients should still be monitored closely in terms of their blood counts and monitoring their transfusion needs and for any issues such as infection, etc. Another oral version is the CC486 or oral azacitidine. This drug has been approved in the US for maintenance in older patients with acute myeloid leukemia after curative intent chemotherapy that was not completed. So basically after induction or consolidation for patients who are 50 and older. So it's very important to know that this drug, while it can cause hematologic improvement and transfusion independence in this phase 3 in MDS, this has not been approved in the US for MDS. So the only drug that's currently approved in the US is the oral version of decitabine. How about some of the new drugs that are in development? So venetoclax, many of you are familiar with this drug by now. It's already approved for older unfit patients with acute myeloid leukemia. And venetoclax is a PCL2 inhibitor. So PCL2 basically is an anti-apoptosis protein. As you can see here, it sequesters the pro-death proteins such as PIM. And what venetoclax does is that physically displaces those pro-death proteins, which will go to the mitochondria, to the mitochondrial outer membrane, and basically create a hole, and that will lead to basically intrinsic apoptosis. Patients with MDS and acute myeloid leukemia are primed to have this apoptosis because of the high stress on the cells. So there is a lot of those pro-death factors, and one of the mechanisms that MDS cells overcome this is by increasing the expression of PCL2. Azacitidine, also one of the mechanisms of resistance to it is by increasing PCL2. So based on this and based on the success of the venetoclax in older unfit patients with AML, there have been a number of trials initiated in patients with MDS. So two of those trials I'm going to show you results from, and those again have been presented in ASH more than once, and there's an update from both of them being presented in next month in ASH 2021. So the first trial is in the frontline setting in which azacitidine was combined with venetoclax. Venetoclax was given day 1 through day 14, and the dosing was increased 100, 200, 400. And the dose that was selected for expansion is 14 days of venetoclax. So this is important to note, because in AML, we give venetoclax continuously. In MDS, we only give it for 14 days. And we do the same adjustments in terms of the venetoclax dosing when you give concomitant therapy, such as azoles or other drugs that interfere with the CYP cytochrome. So these are the results, initial results from this trial. And again, this is an ongoing trial. It's a single arm trial. However, the early results from this trial has been encouraging. You can see the overall response rate was around 80%, 40% complete responses. Median response duration is 13 months. And patients also were getting to responses much faster. So the median time to response was 2.6 months. As we discussed with azacitidine, is around 4 to 6 cycles. Here you are getting to a response within 2 months. The response is longer. And therefore, and also there's a high incidence of transfusion independence. So based on this data, which is very encouraging, a randomized trial has been initiated, which I will show you in a second. But before that, I want to show you also the results in this study that we presented in ASH. This one is in the relapse refractory MDS setting. And what you can see here clearly is that patients who have transfusion, who have received venetoclax after having refractory disease to HMAs, venetoclax as monotherapy does not work very well. But when this was added to azacitidine, those patients achieved responses. What you can see here is that the response rate overall was around 40%. Although complete responses were few, only 7%, but you can see here is that many patients achieved hematologic responses. and they achieve transfusion independence. So there is a real benefit here that we are seeing with this type of approach. And the overall survival as well is 12 months, which is much better compared to what you expect in HMA failure setting, which is around 6 months. So because of the success of this venetoclax used in early phase trials in MDS, this now has been taken into a phase 3 trial, Verona. This is looking at the frontline setting in which patients are being randomized 1-to-1 to get azacitidine with placebo or azacitidine with venetoclax. And we have presented the study design in ASCO 2021, where you can see here the primary endpoint is a combined endpoint of complete response as well as overall survival. This is a large study that's aiming to accrue 500 patients. How about other drugs that are in development? Pivonidistat, this is a drug that is a NED8 activating enzyme inhibitor. This is a first in class. It works upstream of the proteasome. And early data with this drug in AML and MDS have been encouraging. I'm showing you here analysis from the phase 2 trial, which was a randomized trial actually, that looked at pivonidistat with azacitidine compared to azacitidine alone and showed higher complete response rate and much longer duration of response with the combination. And therefore, a phase 3 trial was initiated. While we have not yet seen the results of that phase 3, it's called the Panther study, a press release has been issued by the company, which unfortunately indicated that the phase 3 trial has failed to achieve its primary endpoint. And this data also is being presented in ASH 2021. So it's a little bit disappointing because, you know, the early phase with this compound were encouraging, and still not clear why is there big discrepancy with the phase 3 data. But we will be interested to see what are the details of this phase 3 data once it's presented the next month. About other agents, immune dysregulation is an important factor that occurs in MDS and contributes to the disease progression and the disease pathogenesis. You can see here in this slide some of the commonly observed abnormalities that occur with MDS. For example, dysfunctional T cells, increased expression of those inhibitory regulatory T cells, and dysfunctional and deficient NK cells. So all of these basically lead to escape of the plasma from the immune system and lead to progression of acute myeloid leukemia and MDS. So there has been a lot of interest in trying to activate the immune system against MDS and AML, especially that allogeneic bone marrow transplant, which is the most effective and most potent mechanism of action against MDS and AML, is an immune-based intervention. So one area that has received a lot of attention is the use of immune checkpoint inhibition, because as many of you know, there has been a lot of success in using immune checkpoint inhibitors in solid tumors, such as PD-1, CTLA-4, and here I'm showing you some of those antibodies that are in testing in MDS and acute leukemia, as well as some of the other novel checkpoint pathways that are being targeted. We conducted we published really the first trial devoted in MDS, basically, which was a multi-center phase 1 trial of ipilimumab. And we used here single agent ipilimumab in patients with MDS after HMA failure, based on data suggesting that HMA failure is mediated by increased expression of CTLA-4 and PD-1, PD-L1, suggesting that this could mediate resistance. And unfortunately, the clinical results were not great here. While we showed that the use of ipilimumab in this setting, the anti-CTLA-4 agent, was safe and tolerable, in this investigator-initiated study of 29 patients from 6 centers, we showed that response rate was low, only 3.4%. One patient responded with a marrow CR. However, some patients achieved durable disease, a durable stable disease, and that's a benefit that we also see in solid tumors. Of course, it's very difficult to ascertain from a single arm trial, but that suggests that some patients, if selected, could benefit from this type of therapy. And to try to identify some indicators for response, we looked at some biomarkers. For example, we found that increased expression of this co-stimulatory marker called ICOS seems to correlate with clinical benefit to this therapy. We also found that there was increased peripheral T cell diversity in the receptor, in the T cell receptor diversity. However, that did not correlate with clinical outcomes. And we looked at a large number of other possible biopredictors, such as changes in the T cell absolute lymphocyte count, in the T cell, in the T regulatory frequency, etc. But we could not identify other markers. So this basically got us thinking, what is driving the resistance to immune checkpoint inhibition? We see a lot of immune cell T cell exhaustion in MDS that correlates with progression. We see activities in solid tumors, but here in MDS, we don't see activity. What's the reason for that? So we and others have shown that myeloid-derived suppressor cells seem also to increase in MDS, and they seem to also correlate with the disease progression. So the more progressed MDS, the higher the frequency of those myeloid-derived suppressor cells, which contribute to the inhibitory microenvironment. And my colleague Tae-Kon Kim have conducted a number of nice experiments that also suggested that the use of entinostat might be synergistic with PD-1 blockade, because it seems that the response to PD-1 blockade is inhibited by those myeloid-derived suppressor cells. So when you add entinostat in these murine myeloid leukemia models, you are overcoming these myeloid-derived suppressor cells and achieving synergistic activity. So based on this data, we have initiated a multi-center phase 1 study looking at combining pembrolizumab with entinostat, the histone deacetylase inhibitor, after HMA failure. And this is an ongoing study that has fully accrued now, and we are hoping to present data in the next year or so. Most of the data I showed you with immune checkpoint inhibitors are single-arm studies. And I think it's very important to better understand the activity is to look at randomized data. So here, this is the largest study, and actually really the first randomized study to be conducted using immune checkpoint inhibition with azacitidine. So here, azacitidine with durvalumab was the combination that was used. Durvalumab is an approved PD-L1 inhibitor that has activity in multiple solid tumors. And here we randomize the patients to receive azacitidine or azacitidine with durvalumab. While the combination was tolerable and the immune-related toxicities were infrequent and manageable, we did not observe an improvement in the primary endpoint of the study, which was overall response rate. So you can see here that numerically it was slightly higher, 61% compared to 47%. However, this was not statistically significant. And when you look at survival endpoints, such as progression-free survival as well as overall survival, you can see that there are not significant differences. And therefore, this was clinically negative trial. We did look at basically subsets to see if any patient subset might have benefited. And one particular subset we focused on is TP53 mutated patients, because those patients tend to have the worst outcomes, but also because there is data suggesting that there is an increase in the inhibitory microenvironment with TP53 mutations. However, even among those patients, we did not observe any improvement in the overall response with the combination or in the survival with the combination compared to monotherapy. However, I think that this data does not mean that immune checkpoint inhibition is not, as a class, is not going to be effective. I think the data is different between different immune checkpoint inhibitors. So another, I think, very interesting immune checkpoint inhibitor is sabatolimab, or MPG453. This is an anti-TIM3 antibody. And TIM3 basically is an inhibitory receptor that's expressed not only on T cells, but also on the innate immune system cells, such as macrophages, monocytes, and NK cells, but also importantly on the leukemia stem cells. And it seems it's not also expressed on normal hematopoietic stem cells. So this drug really, or this antibody, has a dual mechanism of action. One, by stimulating the immune checkpoint inhibition, stimulating the immune checkpoint pathway and activating the T cells, but also it works on the leukemia stem cell directly by inhibiting the interaction of the ligand with the TIM3, which is expressed in the leukemia stem cells. For example, this galectin-9 is a ligand that has been shown to promote leukemia stem cell survival. So by inhibiting this pathway, this drug will target the leukemia stem cells. So based on this preclinical data, a number of studies have been initiated. The phase 1 study combined hypomethylating agents, azacitidine and decitabine, in multiple doses with sabatolimab, as you can see here in this dose escalation study. And the data has been presented more than once as well. Also, there is an update of this trial in the ASH meeting next month. But the overall responses were around 60%. The CR rate is 25%. Might not look much higher than monotherapy. However, I think very interesting aspect with this drug is the durability. And the immune checkpoint inhibition used, the best advantage might end up being durable responses. So what you can see in the swimmer's plot to the right is that some patients with high and very high risk disease seem to achieve prolonged responses. So I think this is a very important thing that will be followed over time. And also recently data suggested that patients who have TP53 seem to benefit in particular from this drug. Because of all this interesting data, the Stimulus program has been initiated. We presented on the details of this program over the last ASH and other meetings basically, but here you can see some of the pivotal trials that are going on. The MDS, there's a randomized phase 2 trial called Stimulus MDS-1 that has completed accrual, and we are waiting now for results, accrued 128 patients. There's the Stimulus MDS-2, which is a phase 3 trial of sabatolimab with azacitidine versus azacitidine with placebo. This trial is still ongoing. And then also there are trials in AML in which azacitidine with venetoclax is being combined with this drug sabatolimab. So I think we are waiting for all the results of these trials to see whether this drug will have a role in the treatment of MDS. Another interesting drug that many of you might have heard about is magrolimab, or the anti-CD47. So CD47 is the don't eat me receptor that's expressed in many normal cells. And it's basically an immune checkpoint inhibitor, but it functions against macrophages, against the innate immune system. Leukemia cells and MDS cells exploit this pathway by overexpressing CD47. And therefore, this gives the rationale of basically interfering with this pathway by using antibodies that block the CD47 or the SIRP-alpha, which is the partner on the macrophages. And one of the most advanced drugs in development is magrolimab. There's now a number of other agents that are in development. This, as monotherapy, again, does not work very well, but in combination with hypomethylating agents. And there is data that hypomethylating agents such as azacitidine will increase the prophagocytic signals in MDS and AML through a reticulin mechanism. And you can see the clinical data is quite interesting, around 40 to 50% CR rate. Most patients had blast reductions. You can see a data from MDS, but from AML, but the data from MDS is also particularly good. But I think there's a lot of interest, especially in TP53 mutated patients, which again seem to respond to this combination. However, this is a single arm study. We don't have randomized data yet. So there's multiple randomized trials in AML and MDS called the ENHANCE trials that will look at the benefit and the use of magrolimab in AML and MDS. In the last couple of slides, I'm going to talk about luspatercept in the frontline setting. As I mentioned, luspatercept is approved after ESA failure in patients with ring sideroblast. The COMMANDS trial is an ongoing phase 3 trial that's looking at luspatercept as a frontline treatment. So it's luspatercept versus erythropoietin stimulating agents, but also importantly in patients who don't have ring sideroblast. So this is a trial that will answer the question about use in patients who do not have ring sideroblast. Another drug that's an advanced development is imetelstat. This is the first-in-class telomerase inhibitor. Again, the data here you can see in lower risk MDS, regardless of whether having ring sideroblast or not, showed transfusion independence rate that was high, around 38%, but the durability is actually quite impressive with this agent. Many patients have durable responses beyond a year or two, and therefore phase 3 has been initiated called the IMerge, and this actually IMerge study has just recently fully accrued. So we are waiting for the results from that as well. So in summary, there are a large number of drugs that are being tested. I made an overview of most of those active agents, but there are also IDH inhibitors. We have data that IDH1 inhibitor, ivosidenib, and the IDH2 inhibitor inacitinib and other agents in this class for the around 10% of MDS patients who have those mutations could benefit from these drugs, whether as monotherapy after HMA failure or in combination with HMA, as well as FLT3 inhibitors. But it's a very exciting field. I think very importantly, trying to put patients on clinical trials is very, very important, because this is how we keep moving the field forward. And as I showed you, the outcomes with HMA monotherapy alone is not ideal. So I always encourage patients to go on clinical trials. So at the end, I would like to acknowledge the foundations that supported my research. This is my email. This is my Twitter handle. Feel free to reach out to me about any questions you might have. And again, thank you so much for the opportunity to be here with you today. And apologies again about the technical glitches at the beginning.
Thank you, Dr. Amer Jaden. Are you able to hear me?
Yes.
Okay. So I request all of our discussants to open their video. We will have an interactive session after this lovely talk. We've been updated on MDS, all aspects so beautifully, and the data shown by you is very impressive. You have brought us up to date. So let us begin with some of the discussants. May I ask Dr. Roshni Pandey to ask her question?
Good evening, sir. With the advent of combos with hypomethylating agents in MDS, would metronomic dosing be more appropriate than a maximum tolerated dose? This I'm asking with respect to using AZA with VEN and maybe posaconazole. Should we use 400 mg or can we use a dose of 100 mg?
You are talking about the venetoclax?
Yeah. In general,
Yeah,
in MDS with respect to venetoclax in particular.
Correct. Yeah. So I use the same dose modifications that we use in AML, basically. So meaning that if you are adding a strong CYP inhibitor, we often use here voriconazole in the US. So we reduce the dose of venetoclax to 100. And with posaconazole, actually it depends on the country, because the label in some countries recommend using venetoclax at 70 milligram. Here in the US, we use 100 also. If you use posaconazole, we use 100. If you use voriconazole, we use 100. If you use a moderate inhibitor such as fluconazole, we use 200 milligrams of venetoclax. Regarding your question about the dosing of HMA therapy, it's actually a very interesting question, because there's some nice data showing very small doses of decitabine leading to responses. We have data showing that 21 days of HMA therapy can work, and we have data showing that 3 days of HMA therapy in lower risk MDS can work. So I think the data is, somewhat all over the place. HMAs continue to be a very fascinating group of drugs, because we still don't fully understand how they work. We don't fully understand the resistance mechanisms. I tend to stick to the schedules that are shown to improve outcomes in clinical trials. So if I'm treating a high-risk patient, I would give 7 days of azacitidine or 5 days of decitabine. In lower-risk MDS patients, in which survival is not the ultimate goal, I can use abbreviated courses like 3 days of each. But I think the question of dosing is important to study in clinical trials.
Thank you, sir.
Sure.
Thank you. Anybody would like to ask a question? Please go ahead. Whoever.
Can I go with the next question?
Yes, Roshni, go ahead. And others whoever wants to ask, please put the raise hand sign. Yeah. Shilpa has put up. So
Is the-
Roshni is Shilpa.
Is the prognostic impact of some genes like P53, SF3, beta 1 and TET2 modified by the variant allelic frequency? Or should we just take it as positive or negative, means mutant or wild type?
That's an excellent question. I'm hoping that the presentation I alluded to in ASH, looking at the revised IPSS incorporation of molecular data, what we call the molecular IPSS, is going to shed some light on this. What has been presented so far from multiple institutions is that the variable allele frequency does seem to impact the prognostic picture. So patients, for example, with TP53 who have more than 40 to 50% variable allele frequency, they seem to do worse. Other studies have suggested if you have biallelic dysfunction, those patients tend to do worse, while those who have monoallelic, so basically 40% or less, might act similar to the wild type disease. So in clinical practice, I tend to be somewhat cautious about applying these because there are many different factors that could affect determination of the allele frequency, as well as commutations and other cytogenetic data. So I tend to think about this more as a continuum rather than the patient is CP53 mutated or not. It's still an evolving field, and I think the presentation I mentioned hopefully will give more data in that regard.
Thank you, sir.
Sure.
Dr. Roshni, Dr. Shilpa. Unmute yourself, Shilpa.
Talk. My question is, in a case of intermediate risk MDS, how frequently do you go ahead with the molecular testing? That means, is there a role for repeat molecular testing if it is done once at the baseline and there are no high risk features? And if so, like if there is a role for repeat molecular testing, how frequently should you repeat it? And is there a role for repeat bone marrow if there is no progression in the disease in terms of cytopenias?
Yeah, very good question. Actually, a number of questions. Let me start by the intermediate risk. So I think the intermediate risk, there are different ways of approaching that. I alluded in one of the slides in terms of how I think of intermediate risk group, because sometimes those could be in the lower risk and sometimes could be in the high risk disease. I think the simplest approach is to look at the IPSS-R score. So if they have 3.5 point score, they belong in the lower risk. If they are 4 or 4.5, they are in the high risk group. But other ways to look at this is what you mentioned, is looking at the molecular markers. So if someone is intermediate risk, but they have a bad mutation, if they have TP53 or ACXL1, those patients I tend to kind of worry about. And especially if they are younger, I would think more about transplant. I would look if they have a donor and discuss transplant with them. In terms of how frequently do you repeat the bone marrow and the molecular assessment, I tend to do it at time of clinical change or progression, or if the patient is a transplant candidate. If someone is I'm trying to get someone to transplant, I would do the bone marrow clearly to assess if they are in complete response, because ideally you want to have the patient with the lowest blast count you can before going to a transplant. In someone who's not a transplant candidate, I tend not to repeat the marrow beyond the best response. Like once we know the best response of the patient, I don't do it like every 3 months or 6 months, because there isn't much you are going to do based on the result. You'll continue with the HMA treatment unless the patient has clear progression. However, if the patient does have evidence of progression, so they are plaques in the blood, worsening blood counts, then I would repeat the bone marrow and do the molecular analysis. The reason for that is in the US, I have access to other drugs as well. So if the patient did not have an IDH mutation but develops an IDH mutation, I could use off-label IDH inhibitor or FLT3 inhibitor. I showed some data suggesting that, for example, if a patient had RAS mutations, you could consider a MYC inhibitor. So all of those are, kind of case-by-case basis, but I tend to repeat the molecular assessment at those time points. I generally will not do it for kind of just routine assessment in patients.
And one more question, if I am permitted to ask.
Go ahead.
Sir, in your practice, when most of the time we are seeing some high risk MDS patients in the range of like 5th decade or the 6th decade, in case of transplant, would you consider a RIC transplant followed by disease monitoring, or do you consider a myeloablative transplant conditioning protocol for MDS?
Yeah, in any patient who can tolerate myeloablative conditioning, I tend to recommend myeloablative conditioning because, again, we have some data suggesting that myeloablative conditioning in those patients tend to have better disease control. So it depends on the institutional cutoff. In my institution, we can do myeloablative up to the age of 60, 65. I know in other institutions, they don't do it beyond 55 years old. So it depends on what's your transplant kind of practice is. But as a rule, if the patient can tolerate myeloablative conditioning, I tend to do it, especially in patients who have persistence, like, not full clearance of the blast. If they still have, let's say, 5-6% blast, I tend to push more for myeloablative conditioning.
Thank you, sir.
Thank you, Shilpa. Dr. Kunal?
Yes, very good morning to you, sir.
Thank you.
My question to you is, because you have used luspatercept in your clinical practice more often, so in low-risk MDS patient with ESA failure, have you tried luspatercept and lenalidomide both in your patients?
Yeah, I haven't, and there are like clinical trial concepts looking at at those type of combinations. I tend to use in my practice right now, I tend to use luspatercept ahead of lenalidomide. The reason for that is lenalidomide can cause lowering of platelets, can cause lowering of neutrophils, fatigue, GI upset, rashes. Many older patients might not, necessarily tolerate it, but also the response rate is around 25%. Luspatercept, on the other hand, generally does not has very minimal side effects. It's every 3 weeks. It's a subcutaneous injection. So if the patient does not have ring sideroblast, I favor luspatercept over lenalidomide. If the patient has ring sideroblast, I certainly would use luspatercept ahead of lenalidomide, but I would not combine the two until we have clinical data. And I think it's important to point here, another reason why I tend to use luspatercept before lenalidomide is because the data from the Middle East trial only allowed HMA ESA treatment before. So we still don't know how well luspatercept will work in someone who have received lenalidomide before. In my experience, people who have received lenalidomide and HMAs, and then you try luspatercept, doesn't work very well. But we need clearly more data on that.
Okay, sir.
Thank you, Kunal. Yes, rest of the faculty, you'd like to ask anything? Yes, go ahead, Giripuja. We can't hear you.
Hello.
Yeah, now we can hear you now.
Hello, sir. My question is mainly in deciding between azacitidine and decitabine, most of the novel agents which you showed us, all the studies are combined with azacitidine mainly. Is there any particular situation where decitabine is preferred over azacitidine, or any particular mutation where one is definitely preferred over the other in low risk or high risk?
Yeah, so clearly this has not been kind of compared in clinical trials head to head of the two drugs, but my practice, I don't see them different. You're right that the reason why azacitidine is almost always the partner in the large registration trials is because it's a drug that has improved survival and the one that's most registered in the US. I think the most important element in my mind is that there is an oral version of decitabine, that is already approved for MDS, while the oral version of azacitidine, as I mentioned, is not. So I think it would be interesting, and some of that stuff, some of that testing is already happening now, where several of those combinations that you showed will probably be combined also with the oral version of decitabine. So I don't think there is any reason to think that any particular combination will work better with azacitidine compared to decitabine, or based on any kind of molecular alteration.
Like some studies said in TP53 mutations, particularly, is there like decitabine is preferred over azacitidine, anything like that, sir?
I don't think, this data, what was published in the New England Journal of Medicine, I think there was a lot of debate over that. I personally don't think that the 10-day decitabine use has any difference compared to the 5 days. And we actually have data now from the MD Anderson group comparing 10 days versus 5 days of decitabine, and they showed no difference. People with TP53 mutation, we have also data from the MD Anderson in which decitabine with venetoclax was used for TP53, and those patients did very poorly. The survival was like 5-6 months. So those patients, I think, are unfortunately in a very bad place. And I don't think the answer to them is 5 or 10 days of decitabine. You need novel drugs. You need different ways of kind of going after the disease biology. But I don't think it matters 5 or 10 days of decitabine.
And one more question, sir. Like any role of JAK inhibitors now, like the early studies, maybe like ruxolitinib, like can we combine? Like what is the role right now in MDS?
We don't use it. It's not approved. I don't use it in my practice. The only situations of JAK inhibitors, that comes in MDS really is in post-transplant, where some patients can develop acute GVHD, and we use JAK inhibitors in that setting. But I generally will not use it for treatment for MDS. However, in patients with CMML, chronic myelomonocytic leukemia, which is across the, related, but it's not MDS now. It's a separate disorder, MDS, MPN overlap. Some patients who have big spleen, constitutional symptoms, they have proliferative features. There is some data that ruxolitinib might help in those patients. So I tend to use it as a second line after HMA treatment in CMML proliferative patients. If I don't have a transplant or a clinical trial, I would consider ruxolitinib.
Thank you. Anybody else?
What is the future?
Yeah.
So may I speak?
Yeah, go ahead.
Yeah.
Anybody
What is
wants
the
to ask
future of
this?
checkpoint inhibitors in HMA failure patients in an effort to overcome resistance?
Sorry, I missed the first part of the question. What is?
In patients who have HMA failure, can we use checkpoint inhibitors to overcome HMA resistance?
Yeah, I mean, that's my hope. I showed some of the data that we've been doing in that setting. CTLA-4 has not worked very well, but there was a study from the MD Anderson which they had some responses. So I think patients with MDS probably are not all behaving the same. There could be certain subsets that are more likely to respond. So I also showed data that myeloid-derived suppressor cells could be mediating resistance. So maybe some combination of immune checkpoint inhibitors might be the way to go. Most of the data with the TIM3 and magrolimab, the novel immune checkpoint inhibitors, they're actually being done in the frontline setting. So I think my general sense with HMA failure in general, it's a very bad place to be. And probably the focus of all clinical research should be on optimizing the frontline treatment so that you are delaying and hopefully at one point in the future, maybe preventing HMA failure. Because once HMA failure occurs, usually it's a very bad place to be.
Thank you, sir.
Sure.
Anybody?
A young male, 40-year-old male with excess blast about 15% and a T53 mutation and monosomy 7. So what would be your approach, sir?
Yeah, good question. And this is a patient I would use HMA therapy followed by transplant. I would do a myeloablative transplant following HMA monotherapy. Some people, I think without the TP53, some people might suggest using intensive chemotherapy. I think having the TP53 kind of decreases the appetite for induction significantly because we don't think those patients respond very well to intensive treatment. In the US, some people will add venetoclax to the patient that you just described. They would give HMA azacitidine with venetoclax and then go to transplant, but they would do that off-label. I will not use venetoclax off-label in most patients until we have like the randomized phase 3 data kind of supporting its use.
Okay, sir. Thank you.
Sure.
Any other question, please?
Sir, I have a question, sir.
Go ahead.
Sir, you were talking about using of immune checkpoint inhibitors. Sir, is there any evidence that using upfront any immune checkpoint inhibitors with HMA inhibitors is there any evidence that it delays the progression to AML? Any checkpoint inhibitor?
So like the only way to know this answer for sure is randomized trials, because most of the data that have been done were single arm trials. And I think any kind of time to event endpoint, like time to progression of AML, requires a control against HMA monotherapy. So in the only study that was randomized, which I showed, the Fusion 001 study, AZA versus AZA with Dorva, we did not observe any difference in progression-free survival or overall survival. So I can tell you with durvalumab, it does not seem to be the case. However, with the novel TIM3 and immune checkpoint inhibitors such as CD47, randomized trial with the TIM3 is already completed, randomized phase 2. So we might have an answer for that in the near future, but currently we don't have the answer for this.
Yes, sir. Thank you.
Sure.
Thank you, Ayan. Any other, please? Yes, Kunal.
Sir, what is your approach for very low risk or low risk IPSS-R patients with poor mutational status, poor mutational markers?
Yeah, I think that's a good question. It depends on the age of the patient and, what are the goals of care. I think someone who is younger, who has lower risk disease and a bad mutational marker, I tend to think about transplant. I would look for a donor, but I generally will not transplant the patient until we see some progression. However, this is a patient I would monitor very closely, repeat the bone marrow if the blood counts drop. But I would not take them to transplant from the get-go just because they have ACXL1, for example. Again, I think that's going to be a very important question to kind of figure out, to see what this molecular IPSS will have to say about that. Because currently, as you know, the revised IPSS does not account for those molecular alterations.
Okay, sir, suppose if the patient is transfusion independent, would you like to follow up this patient closely or start any HMA therapy straight away?
No, I would not treat I would observe them like as if they had normal, like no adverse molecular features. So I would just, observe the patient. If they have if they become transfusion dependent, I would give them ESA. I would treat them the same way regardless of the molecular alteration that they have.
Right. Any more? Okay. If there are no more questions, Dr. Emmer, I'm extremely grateful to you for sparing your time. Lovely talk, great interactive session. You have been very helpful to us in educating this community over here. The large number of people who have registered from India and surrounding countries, almost 1/3 are fellows and 2/3 are the seniors. They all must have benefited tremendously from your talk in this session. Thank you so much. Thank you.
Yeah, thank you so much. My pleasure. And I hope next time I will be able to be in India in person. I've been there a couple of times and I really enjoyed being there. And I look forward as COVID winds down to kind of resume the in-person networking with all of you.
Right. Thank you. And
Sure.
for the official vote of thanks, may I request Mr. Ashutosh Shukla?
A big thanks to all our elite speakers, to the elite speaker, Dr. Amir Zidan, for the wonderful and insightful talk on novel therapies for MDS. Thanks to all the discussions for making today's webinar highly interesting. I am sure all the participants must have felt today's discussion insightful, interesting, intriguing, enlightening, and much more. A big salute to Dr. M.B. Agarwal, sir, whose untiring effort to impart education through a series of webinars is phenomenal. I am thankful to our event partner, Mice Ideas. Last but not the least, I am thankful to the entire sales and marketing team of Adley for their follow-ups with all India doctors. Thank you so very much. Good night.
Bye.
Bye-bye.